let's start our program tonight. And Tina, I think we all agree that 2020 has been quite a year with COVID-19 and how it's changed and affected our lives. But also it's been a year where our awareness of racial and ethnic disparities in healthcare has grown related to issues of access, treatment, and vulnerability, especially with COVID. And I'd like to begin tonight discussing how these disparities manifest in the management of IBD. We posted a couple of polls on Monday Night IBD Twitter handle, and I'd like to share this poll with you, and I'd like to invite the audience to participate in this poll, please. All right, so this is the poll we have that we had on Twitter, and most people felt or were aware that the incidence of IBD is significant in minority and has been increasing in recent years. So we'll see what our audience shows. So our Twitter audience and our live audience seem to be in agreement with this assessment. So I'm going to start tonight, following this poll about the incidence of IBD in minority and what that means. There's definitely an increase in the incidence of IBD in the United States. And we still have more new IBD cases per year in whites compared to non-whites. But the rate at which this increase is happening at a much higher amplitude in non-whites versus whites. So 135% increase in non-white in the last 40 years versus 39% increase in whites in IBD. And it's important to remember that by 2050, so in the very near future, up to half of the US population will be made of minorities, mainly Hispanic and African American. So it is very important for us as a medical community, researcher, clinician, to really look whether or not there are potential differences in disease characteristics, natural history, and treatment response. What we do know now is that there's definitely a difference in healthcare utilization, and there are many barriers to care for patients with minorities. And it's important for us to be aware of that so we can improve access to care for IBD patients of all races and ethnicity. I want to share with you a few studies looking at that and looking at how minorities with IBD utilize healthcare a little bit differently. To your left, you have a graph looking at hospitalization, and there's definitely a disproportionate rate of hospitalization in Black patients with IBD compared to white and Hispanic. And on the other hand, Blacks and Hispanic have a higher utilization of steroids compared to whites. So the question can be, well, is it because Black and Hispanic have a more aggressive disease phenotype? They need to be hospitalized more often, they need more steroid. I don't think the answer is in difference in phenotype. It's more a difference in access to care and socioeconomic status. If you look at the bottom row of this slide and looking at the Medicaid insurance, you'll see that having Medicaid is associated with a higher risk of using steroids compared to having private insurance. And in other studies, Medicaid and low socioeconomic status were associated with higher steroid use, higher use of urgent care like the ER, and being hospitalized, and also higher incidence of inpatient mortality. So even though Medicaid can really help with the cost and cover some cost, the low socioeconomic factors really impact engagement in IBD care and continuity of care and appropriate care. And our patients who are underinsured or who have a high healthcare costs, who are losing insurance or being in transition between insurance and have inconsistent access, have increased visit to the ER department, urgent care, hospitalization. And at the end of the day, all this leads to an increase in IBD-related disability. So I would like to know now, how does your practice look in terms of IBD and what kind of patient we are seeing in your practice? So Tina, as our audience is taking that poll, I would like to turn to you and ask you how, I like this last answer. You know, I have a diverse population, but I'm not sure how to apply what I see in randomized controlled trial for therapies or data about IBD patients that where the main demographics has been white patients.
Yeah, I mean, I think it's actually very challenging because if you look at the clinical trial data, the vast majority of the participants are actually white. So the question is, just like it is with any other comorbid conditions, elderly, how do we extrapolate, or can we extrapolate that data to a very diverse patient population? And I'll say in my practice, I am seeing a lot more diversity, but we're also seeing diversity in terms of, you know, at what stage in their disease they're presenting. So I think it actually falls into various buckets. First is recognizing that Crohn's disease and ulcerative colitis can be diagnosed regardless of what your ethnic background is. It isn't just a Jewish condition. But I also think part of it is understanding truly what the natural history is, because although we presume that it is similar to the white populations, there needs to be far more studies. And as you and I know, there are a lot of people who are very interested in this and want to explore this further, such as my colleague, Dr. Dermot McGovern at Cedars, and he's actually participating in a lot of multi-center collaborative studies trying to understand genetics and natural history. And with that, we have to also encourage access to treatment and really make it accessible to use all of these practice standards, regardless of what the ethnicity is. So it really has to be democratic, our treatment.
I can't agree more. All right, so this is our audience. So our audience is seeing a more diverse population, and like you, Tina, they're wondering how can we apply what we know from the data now to our non-white patients? So absolutely highlighting the need for more studies into how IBD behaves and what kind of therapy we need and what are the genetics behind IBD and risk factor in our minority population versus whites. And definitely up to a quarter of our respondent here see that their patient demographic has been changing in the last 5 years. This is excellent. So we'll start. I think I'm going to hand it to you, Tina, at this point. Let's see. Yes.
All right. So thank you, Aline. This is very exciting and already a lot of fun. So let's dive into our first case. So this is Cecily, and she's a 21-year-old African-American woman, and she's been having symptoms for the last 3 weeks. They include intense abdominal pain, followed by urgent bloody diarrhea, up to 10 bowel movements a day. And she also describes abdominal pain and distension that's relieved with vomiting. She also reports new onset joint pains involving the knees and the ankles, as well as some lower back pain or mid back pain that's particularly stiff in the morning. Over the past 3 weeks, she's lost 15 pounds due to a poor appetite, and overall, she's feeling pretty fatigued. In terms of other relevant history, she smokes e-cigarettes, just like a lot of the other young folks are doing nowadays. I can say that because I'm no longer young. And on physical exam, it stinks to age, but it's very important to study. On her physical exam, she has a notable tenderness to palpation in her right lower quadrant, and you can tell that her left ankle is slightly swollen and tender. With basic laboratory data, we know that her C. difficile is negative, her stool cultures are negative, but her C-reactive protein is elevated at 10. So she gets a colonoscopy, and endoscopically, the TI is noted to have deep mucosal ulcerations with cobblestoning, as well as an ulcerated and stenotic ileocecal valve. Throughout her colon, she has scattered, deep, almost punched out looking ulcers, and the path shows features of chronic and severe active ileitis and colitis without any viral inclusions present. So at this point, I'd like to ask the audience, we'd like to hear your opinion about this patient. We'll revisit this question later, but we'd like to vote. How would you treat Cecily? All right, so at this point, we need to discuss what some of the risk factors are to actually help us with our decision-making when it comes to treatment of Crohn's disease. So there's 2 different aspects that we have to consider. We have to consider disease activity, which is clinically how the person is feeling today or when they're in your office, versus disease severity, which is the likelihood their Crohn's disease is going to progress over time. So risk factors for poor outcomes, which is disease severity, are important to assess when you're meeting a patient to decide what their treatment should be. So some of the risk factors for poor outcomes are young age at diagnosis, less than 30, extensive colitis, ileal or ileocolonic involvement, perianal or severe rectal disease, the presence of deep ulcers on colonoscopy, a prior history of surgery, or evidence of what's called B2 or B3 disease, stenotic or penetrating disease, and a smoking history. So if we think about Cecily, she's 21, so she has that first risk factor, young age of diagnosis. She has ileocolonic involvement with deep punched out ulcers throughout her entire colon, as well as a cobblestoned and deeply ulcerated terminal ileum. So that meets three more criteria. She doesn't have any perianal disease yet. However, there is an increased likelihood of perianal disease amongst African Americans, so it's something that we have to worry about down the road without early intervention. She hasn't had a surgery yet, but she does have a stenosis that was commented on her initial history. And even though she doesn't smoke cigarettes, she smokes e-cigarettes. So the true risk of that remains to be seen. So now we know that Cecily has multiple risk factors for poor outcomes. So she has moderate to severe disease severity. And clinically, she's quite active. She has 10 bloody bowel movements a day, abdominal pain, obstructive symptoms, extraintestinal manifestations, as well as weight loss and an elevated C-reactive protein. So now we know we need to treat her with an agent that's appropriate for moderate to severe disease. And according to our recent evidence-based guidelines, we have to remember that oral corticosteroids in the setting of Crohn's disease are only induction therapies. They're not meant for maintenance. So as soon as we start a patient on corticosteroids, we have to start thinking about what our steroid-sparing agent is. And in 2020, we are lucky in the sense that we have multiple options, such as thiopurines and methotrexate, although it's debatable for this type of patient if we're going to use it as monotherapy. A lot of it has to do with access. Or we can use anti-TNFs as monotherapy or in combination with an immunomodulator or methotrexate, vedolizumab, and ustekinumab. And as we'll talk about later on, we also have multiple other MOAs or mechanisms of action in the horizon. So we have to start positioning our agents relative to disease activity and disease severity. So why is this so important? Well, this is actually data that was published earlier this year by Corey Siegel and his colleagues. And it was a retrospective observational study using administrative claims data on patients who were newly diagnosed with Crohn's disease. They looked at over 16,000 patients. And what they found was these patients who were newly diagnosed with Crohn's disease, about 42% of them were initially treated with corticosteroids, but also 35% of them were initially treated with 5-ASAs as monotherapy. And as we know, the data supporting the use for 5-ASA in Crohn's disease is actually quite poor and not evidence-driven. However, what's more disappointing and surprising, and an area we really need to improve upon, is that less than 5% of patients were initially treated with biologics. And you can say, okay, steroids as an induction therapy is reasonable. However, only 19% followed a biologic treatment pathway early on in their diagnosis, even with a course of corticosteroids, compared to 81% who followed a non-biologic treatment pathway. So there's a lot more that we have to improve upon in order to provide our patients with the appropriate evidence-based treatments. Now, what may be driving this? So there may be different perceptions of steroid use. This is actually an important study that was presented by my colleague and great friend, Anita Afzali, earlier this year at ECHO, and it was to be presented at DDW. And they did an international multinational survey study of both patients and providers. And these were IBD providers who saw actually a fairly large percentage of IBD patients with moderate to severe disease activity every month. And of these patients who were surveyed, over 1,300 of them with Crohn's disease, 75% reported receiving at least one course of corticosteroids. Now we have to ask ourselves, okay, what's the difference between providers and patients' perceptions of steroid use? So physicians and patients both reported similarly that about 35 to 40% of patients took steroids for at least 4 months or more, or even 6 months or more during the past year. However, what's really important is the different perceptions about, is that okay to be on steroids for that long? Only 27% of the physicians were really that concerned about the steroid use, and half were concerned about being on it for a prolonged course of more than 4 months. Whereas from the patient perspective, almost 50% of them were concerned about being on steroids, and over 2/3 wanted to stop the steroids as soon as their disease was under control. And knowing that steroids are only used for induction, this means we have to choose an appropriate maintenance strategy, steroid-sparing maintenance strategy, so that they don't need repeated courses of steroids. So which one to choose? I told you that there's multiple mechanisms of action. We have at least 3 different classes of types of biologic mechanisms that we can choose from. So this is a systematic review that was published by Sid Singh at UCSD a couple of years ago. And basically they were looking at the efficacy of the various anti-TNF, vedolizumab and ustekinumab compared to placebo. Now, it's very important. You have to be cautious about applying these systematic reviews to practice, because at face value, it looks like the anti-TNFs, infliximab and adalimumab, are the most effective compared to placebo relative to certolizumab, vedolizumab, and ustekinumab. But my take home that I look from this chart is everything is more effective. So you have to choose something. What's not effective is doing nothing. So this is where you have to look at the patient's perspectives, shared decision-making, their risk factors, their likelihood of progression, and choose the right agent according to the patient's needs. So the reason why it's important to start anti-TNFs early is based on multiple studies. And here's an example that's published from David Rubin a few years ago. Basically, they looked at claims data of close to 4,000 patients. And these are patients who were newly diagnosed with Crohn's disease. And they actually stratified the patients into 3 different groups. The first group actually were early initiators of anti-TNF, meaning they had their first prescription of anti-TNF within 30 days of their diagnosis. The second group actually had more of that old school step-up model, where they were prescribed an immunomodulator or immunosuppressant, and then if they needed it, then they stepped up to an anti-TNF. The third group stepped up immediately from a course of corticosteroids or aminosalicylates to anti-TNFs. And as you can see from the bars, the group that started with the early anti-TNFs first, which is the solid line on the bottom, they had fewer percentages of patients with continuous use of corticosteroids at month 6, 12, 18, and 24, compared to groups that started with immunomodulators first, which was the dashed lines, or 5-ASAs and corticosteroids, which is the dotted line on top. So the take-home message is, if our patients, and over 2/3 of them in that survey from Anita Afzali's data, want to be off steroids as soon as possible, the best way to do this is to start with a biologic early on. This is additional data from this group looking at another important outcome, which is the likelihood that they're going to need Crohn's disease-related surgery. Now, the dark blue bars on the left represent the patients who started on the anti-TNFs early. And across the board, over time, at months 12, 18, and 24, the group that started anti-TNFs first were less likely to have Crohn's disease-related surgery compared to the other groups that stepped up over time. How about ER visits and hospitalizations, increased healthcare utilization? So this is a study from that was to be presented by Ryan Ungaro and the group at Mount Sinai. And again, they looked at a claims database, and they divided the groups into 2 different groups: early biologic users, which were patients who were prescribed a biologic during their first year of diagnosis, versus late biologics users who weren't prescribed biologics during that first year. And what they found was, at months 12 to 24, which are the blue bars, the patients who started biologics during that first year of diagnosis had fewer hospitalizations and ER visits compared to patients who began biologics later. Again, supporting the notion that if we want to keep patients out of the hospital, off steroids, and avoid surgery, you need an early biologic strategy.